Good morning, everyone. We wanted to welcome you to Workshop 26, Best Abstracts in Endocrinology and Reproductive Health. We are your moderators. My name is Andrea Rowe. I'm an OBGYN with a specialty in family planning at the University of Pennsylvania in Philadelphia. And this is Kara Hugan. She is a pediatric endocrinologist at the Children's Hospital in Pittsburgh. And today we are going to adhere to these following learning objectives. We're going to discuss the effects of ETI therapy on bone mineral density, lean mass, and testosterone levels, review alternative CFRD screening tests, and examine current effects of pregnancy and early parenthood on CF health. Well, we're not going to do that, but other people will. These are the awesome abstract presentations that we'll be hearing from. And then just a disclaimer that our opinions are not necessarily shared by the CF Foundation.
So I wanted to put a plug-in for those that have more interest in learning about all aspects of cystic fibrosis, but especially endocrine conditions and their comorbidities in CF. There's an excellent training, online CME training modules available through the Indiana University. Several years ago, a number of us in the Envision group put together course number 7, but you can use the QR code available up on the screen or see us after if you'd like to learn more about that.
We had another slide, but maybe it didn't make it in. We just wanted to highlight that Endocrine Practice is a journal that is putting out a special issue on CF and endocrine and reproductive health, and we're taking submissions. The due date is November 17th. You can just look it up online. It should be pretty obvious how to submit, but we're taking original research, and we've invited some review articles, so please feel free to reach out directly if you have any questions about that. But Endocrine Practice, November 17th. Thanks.
I would like to go back here and get our first speaker. All right, I'd like to welcome our first speaker today. Dr. Megan Shirley Becerra is a staff scientist investigating CF-related endocrinopathies with Dr. Andy Kelly and her team at the Children's Hospital of Philadelphia. Dr. Becerra will be presenting her work today, Bone Mineral Density in Young Children with Cystic Fibrosis, Pre- and Post-ETI, the BEGIN study. Let's welcome her today.
Will this show up as like an indicator on the thing? No, for the pointer. Yeah, okay. Okay, thank you so much. Thanks to the moderators. Thanks for the invitation to present these data on behalf of the co-authors and all the BEGIN investigators, and I have no disclosures. So bone disease is prevalent in CF. It's characterized in adults by low bone mineral density and increased risk of fragility fracture. In the right panel of this figure from the 2023 CFF patient registry report, you can see that CFBD increases in prevalence with age. But to draw attention to sort of this, like the lowest age range, this is a bit misleading that we have maybe a 0% or close to 0% prevalence in these young ages because we don't screen in those young ages. And then if we see here where we do start to see the line increase, I would just say that we still don't really know, when compromised bone health actually does start, because maybe this is just sort of because we have more screening at those ages. So the CFF guidelines do call for screening by DEXA, dual energy X-ray absorptiometry, in individuals with CF greater than 18 years of age. And it's also recommended in individuals between 8 and 18 years of age in the presence of certain risk factors, like the ones below. You have, low FEV, percent predicted, delayed puberty, history of fracture. The screening guidelines call for hip and spine DEXA in adults and whole body and spine DEXA in youth. So think, we all know that the pathophysiology of low BMD and many other extrapulmonary conditions in CF is multifactorial. So animal models have suggested that CFTR dysfunction directly affects bone cells. This is a figure showing relatively low spine BMD in CFTR null or knockout mice in an earlier study. So if that's the case, then we might expect to see low BMD even in younger kids with CF. But we really don't have a lot of data. Like I said already about, we don't have the screening in those young ages. We also don't have a lot of data either pre or post highly effective modulator therapy, once they came out. So this is one study from 2007 that was nice because it collected data in really young kids, so under 6, and then it also reported the results in kids under 6 without sort of, adding in the other ages. So you could see that they actually, and they did it in lumbar spine, they found quite low BMD Z-scores. And this was even after they adjusted for short stature and delayed puberty. So the Z-score is the standardized score where when you compare to a reference population, you can look at the 0 line on this figure. The 0 is the average compared to the reference population. And to highlight, again, the under 6s are essentially their mean Z-score for the lumbar spine in that young age group is a negative 0.96. One thing to say, though, is that, this is a study from 2007, and we know that there have been increases, even before modulator therapy and highly effective modulator therapy, there have been increases in care. We know that also there's been increases in newborn screening and sort of the ability to detect early. And so, we might expect to see something different now, even before modulators. So for people that are interested in bone mineral density in young children with CF, we're fortunate that we have really great reference data in young children now. So there was this study from Kalkwarf and colleagues from 2022 that it's really the most robust reference data to date for BMD. They measured it at multiple skeletal sites in healthy children aged 1 to 5. They developed these age, sex, and population ancestry specific reference ranges, which you can see an example on the right. Those are the figures from the paper for spine BMD. The dashed lines are an overlay from data from a separate study, which was called Bone Mineral Density in Childhood, and that's that the lines sort of allowed them to smooth the upper edge of the reference ranges and then sort of connect it with 5 to 20-year-olds. So we have just really comprehensive data. So we sort of paired that. I mean, this was an opportunity because BEGIN, the prospective study to evaluate biological and clinical effects of significantly corrected CFTR function in infants and young children, allowed for using those updated reference data with DEXA data because they collected some DEXA in this study. So it's a multi-center prospective study. They enrolled kids with CF at 35 US sites. Now, there's 2 parts to it. The natural history was for, looking at kids with CF, irrespective, or, outside the setting of modulators, or at least highly effective modulators. So initially, the enrollment criteria was less than 10 years in the first part. I would like to say that it was initially less than 5 years. So most of the kids that we have in the DEXA portion and what I'll show the data for are under 5s. This is the updated enrollment criteria now for Part A because there's an extension to the study. And then Part B is the pre and post highly effective modulator therapy part. So that enrolled Part A participants or youth aged less than 7 years who are going to initiate either ivacaftor or ETI. So, and then in the children that were at least 3 years, they performed DEXA at 8 of those 35 sites, and you get aerial BMD is one of the standard output from the DEXA. It's in grams per centimeter squared, and we did the whole body and lumbar spine. So this is just to show a study design overview. So the different boxes and the numbers are months. So in Part A, and the green indicates where DEXA was. We had Part A, you had DEXA collected at baseline, you had DEXA collected in the other green ones you can see, but I'm just going to focus on 0, which was baseline for Part A, and then 12 months past that for the natural history, because that's what we have data for. And then here in Part B, we have data at baseline, which is pre-modulator, and then we had data at 12 and 24 months post Part B baseline. I already said something about the age, but the other eligibility criteria that were important was that they should not have been on a prolonged use of ivacaftor ETI for Part A, and then they had to have their physician intending to prescribe the ivacaftor ETI for the Part B. And then we had, I say we, I mean, it's really all these sites that collected whole body and lumbar spine DEXA using Hologic. We got, height, weight, BMI. FEV is limited because they only attempted it in kids that were at least 4 years. So we don't have data, for instance, for like Part A for our DEXA data. We calculated Z-scores. We did height, weight, and BMI Z-scores using the CDC reference growth charts, and the Z-scores for total body, less head, and lumbar spine using the reference data that I mentioned already. And then we did some longitudinal mixed effects modeling, just unadjusted models. We accounted for within subject correlation, and that was to see how the BMD Z-scores for whole body and spine might have changed across the different study visits. So for Part A, this is obviously just specific to the Begin DEXA part, but there were enrolled 16 individuals. We did, lose a couple from that, but then 11 of them rolled into Part B, and then there were 12 new ones in Part B, and then so we ended up with 23 for Part B, and we didn't have anyone for the DEXA portion of the study that initiated ivacaftor, so everybody initiated ETI. So as far as the baseline characteristics, we had 4.08. These are medians and mins and maxes, and so we had about 4, 3, and 5 for the range of ages for Part A. And I guess like the main thing to point out here is that the Z-scores for height, for weight, for BMI are all good. They're above average, they're above 0 compared to the reference population. We didn't have any FEV. 8, so half of the kids in Part A at baseline had been on lumacaftor, ivacaftor previously. And then in Part B, we have a similar situation with the Z-scores. They look pretty good. I mean, obviously lower than in Part A baseline. And obviously the upper end of the age is going up a little bit there for that one. Okay, so just to show some of the data now, like obviously we don't have like huge numbers here, so it's maybe interesting to just look at the data points. So this is going to be the natural history part. So this is nobody is on ETI. This is mostly data from the Part A part, but then there's also Part B. So I'm going to try to keep this straight because it's a little confusing. So, okay, so we have, these are the baseline measures for total body, less head, A, B, M, D, Z. So you can see that 0 line marked for the average. Down at the bottom left, you can see the median and min-max for the TBLH, A, B, M, D, Z. Sorry about that mouthful, but that's at the bottom left. That's what you have at baseline. Just to remind you, so like what the blue dots are from that first like 0 month for Part A, then the green dots I'm showing are from the 12-month follow-up. And then this is the part that gets a little confusing. Then the orange dots, the orange points come from the Part B baseline. Okay, so that's like also pre-ETI. So, and that was about 17 months on average for the kids as far as like after the Part A baseline. And then this just shows the trajectories for the individual kids. And so these are showing the change in the Z-score for total body, less head. So the negative 0.48 and its 95% confidence interval, that comes from the longitudinal mixed models. So that's a model-based mean and 95% CI. That's the change between baseline Part A and 12 months Part A. And then the negative 0.52 is between baseline Part A and baseline Part B. So now to go through, so this is lumbar spine, still not on ETI. Remind you of where we're getting these data, what visit. Now you can see it without the boxes there to obscure the view. And then there's the trajectories for the individuals, and then you have a median and min-max again at the bottom left for baseline. And there are the changes between baseline Part A and 12 months, and then between baseline Part A and baseline Part B for the, so we're seeing, you know, some indication of a negative trend, but it's not statistically significant. Here's total, okay, so now we're in pre and post ETI. So this is total body less head, ABMDZ. Once again, the median min-max at baseline on the bottom left, and this is a little bit more straightforward. You have the blue dots are pre-ETI, and then the green and the orange are post-ETI at 12 and 24 months post-ETI. Here's the individual trajectories. You know, once again, we're seeing a negative, you know, slightly negative trend in the change across the visits. And then the lumbar spine for pre and post ETI. So once again, the blue pre-ETI, and then you have 12 months and 24 months post baseline Part B. And you see the trajectory, and once again, it's similar. Here, the lumbar spine changes between the visits are statistically significant, whereas in the pre-ETI, we didn't see as much of a change with the spine. But it still looks like relatively modest. But now this is just of interest, I think, because again, like, you know, a relatively small data set still. They are still collecting data for Begin, but this is total body less head ABMDZ scores in the I think it's 8 individuals who had data that spanned basically all or most of the visits through Part A and B. So here you can see everything, like the months on the bottom on the x-axis are set against the baseline Part A as the beginning. So then, you know, you have 12 months passed, and then we know that the baseline Part B was about 17, 18 months on average. And then the indication of where each of these kids started ETI. So you can see that kind of from what we saw before, it does indicate maybe there is a little bit of like a decrease, but even before you started ETI, so kind of in the natural history portion. Lumbar spine's a little bit different, maybe like a little bit more stable, and obviously a little bit higher up, you know, as far as like compared to the average line, but it's also going, it indicated in the models that it was decreasing a bit more in like the post ETI portion, but obviously, you know, again, not a ton of data, so it's kind of just a visual thing. So to summarize the findings, these are really some of the first results presented on bone outcomes in young children with CF using this really robust pediatric reference data. Even prior to ETI, we saw that children with CF, so to kind of, maybe I should have highlighted this in the slides themselves when I had those medians at the bottom left for each of the baselines, they were actually like quite high, right? Like the baseline total body less head and spine BMDZ were pretty robust. Like they were actually, you know, maybe higher than we would have thought. So they looked good at baseline. We did then see a bit of a decrease over the course of the study, both in the natural history and the pre versus post ETI cohorts. So here we don't see any evidence for an effective ETI on DEXA measured BMD, but once again, you know, they're still collecting data. We haven't gotten all the data yet, and we will, this is actually my next one saying next steps. What we will do is we will get the Begin data out to 36 months. We're gonna look at modeling additional, you know, we're gonna look at other covariates and just do more to kind of see if we can get any further insight into whether ETI benefits bone in young children with CF. And then Marissa Kilberg's gonna talk about DEXA body composition data in Promise next, and then, but we will also be able to look at that and Begin. So I do want to acknowledge the study principal investigators, the funding from the CFF, obviously special thanks to the patients and families that are coming in for this study. And I really want to acknowledge the Begin DEXA study sites where it's really not easy to do DEXA, and especially in like a 3-year-old. So this is an image where the kid basically decided, I guess, to run away. You can see that like this is not easy, and it's a testament to the sites and how well they're doing that we actually have only had like 6 unusable scans out of an 85 sets of scans. So they're doing a great job, and they're going to keep doing a great job, and it's really exciting data, and thanks for listening, and yeah, I appreciate it. I'm happy to take any questions.
Thank you, Dr. Becerra. We'll take questions from the audience, and we'll be looking forward to any questions that come through the chat. So I guess I'll start. I am a little surprised with these young individuals that we're seeing some decline in both total body and spine when these are growing kids, but and fairly healthy. Were you and your study team surprised by this?
Yeah, I think we were surprised. I think we were surprised to see that they looked. It's kind of strange, right? Actually, there's almost like a paradox in it. Because I think we were a bit surprised that they were as robust as they were at baseline. So we might have almost thought that they'd be a bit lower, but maybe then not decrease. So I think that, yeah, that is surprising to see them decrease. And it does point to the fact that if that's the case, and obviously, again, these are, it's a relatively small data set. We're going to get more data, and we need to look at this in other cohorts, but I think it does suggest that, maybe there is an effect, a direct effect of CFTR deficiency or dysfunction on the bones if we are potentially seeing something like that so early on. But I think, yeah, it's definitely surprising.
Okay, so I have a very naive question because I don't think about bone mineral density in 3-year-olds very often, which is, this is an age at which there's a lot of linear growth going on, and if you're a little bit off on your normative data, it might impact how the z-score winds up being calculated. So is there a height adjustment built into the normative data, or is there any sort of body size adjustment for your patients who are 3, but they might be big 3-year-olds or small 3-year-olds?
Yeah, so, right, I should have said that in the course of the presentation. So we did have height for age-adjusted z-scores, and we were able to look at those in the models and to see if it did make an impact. And what we saw was that for the total body less head, when you use the height for age-adjusted z-scores, which is recommended to make sure that you adjust for short stature and you don't sort of see like more compromised bones than are what is really there, we saw that you did actually see for the total body less head like slightly larger, like the z-scores were actually a bit higher, which is a good thing. But it didn't like change the results as far as in the models, like anything about the change in BMDZ between the visits. For the spine, when we did the height for HZ sort of check or sensitivity analysis, we didn't really see a difference, but that's something that we'll do again when we have more data and just make sure that that's something that we're checking for sure.
I think we have time for a very short question. Katie.
Actually, all I wanted to say is you did a wonderful job presenting the data, and I always struggle how to do the part A and part B, and that's the best I see it done, and it's better than my poster, so I am so proud of you, and the data was great.
Thank you so much. I appreciate it. Thanks.
All right. I would next like to introduce Dr. Marissa Kilberg to the podium. She will be presenting her data today. Her presenter disclosure slide here is only that she is involved in the CF Envision Cohort 3. Dr. Kilberg is an assistant professor of clinical pediatrics at Children's Hospital of Philadelphia, where she did her residency and her fellowship. She now serves as their program director year of their fellowship. She's also a Vital Talk facilitator where she teaches communication strategies. She's a member, as mentioned, of Envision 3 and has clinical and research interests in puberty, hypoglycemia, and body composition in CF, which she will be speaking about today.
All right. Thank you very much for that introduction, and thank you, Kara and Andrea, for having me here today. Looking forward to talking a little bit now about the PROMISE study and some of the body composition outcomes there. So for those who are less familiar, PROMISE is a large multi-center study that was conducted throughout the cystic fibrosis TDN to assess the impact of ETI in patients above 6 years of age. There's an endocrine sub-study of that during which DEXA scans were obtained to measure body composition in individuals greater than or equal to 12 years of age. And in terms of the body composition components, we look at lean soft tissue, appendicular lean soft tissue, and fat mass. So again, this is the TDN map, and there are 16 sites that had the PROMISE endocrine sub-study. Our inclusion criteria required that age was greater than or equal to 12 years, and individuals that were being clinically prescribed ETI. Folks were excluded for organ transplantation. In terms of the study procedures, we have baseline data as well as 12 to 18 months and 24 to 30 months. As I mentioned, DEXA was obtained as well as frequently sampled OGTTs, but I won't be discussing that today. We have pulmonary function testing as well as anthropometrics, including weight, height, and BMI. With this, we examined baseline body composition and the changes following ETI initiation. We looked at the relationship of changes in BMI with changes in body composition, so trying to understand if changes in fat mass index or lean soft tissue index relative to changes in BMI differed following initiation. And lastly, we looked at the relationship of those changes in body composition with changes in pulmonary function. So I wanted to take a moment to just define the DEXA-derived body composition measurements, because this was a recent paper that was put together and really calls out the need for standardized terminology because there is such inconsistencies across the literature, and it makes it really challenging to give us terms to even describe the population. Things like sarcopenic obesity and normal weight obesity are these terms trying to describe the fat portions in individuals, and if we're not saying the same words, it's really hard to rely on those definitions throughout the population. So this is an example looking at a cross-section of an appendage and looking at the X-ray path that the DEXA goes through. So this path on the left, you are able to, the photons from the DEXA scan are able to distinguish two components, the fat and the lean soft tissue. On the right, you can see that it's also passing through the bone, and so you're able to distinguish the soft tissue and the bone mineral content. And then when we look at that together, we can define our appendicular lean soft tissue, which is including your intracellular and extracellular water, your intracellular and extracellular proteins. And if you add bone mineral content to that, you now have your appendicular lean mass. So trying to just get the terminology straight. And I think this is a really nice way to visualize it that they provide in this paper. So you have your appendicular lean mass on the left. That consists of your skeletal mass, your skin and soft tissue, your fat mass, and your bone mass. So if you take fat out of that, you now have appendicular lean mass. If you take bone mineral content out of that, you have appendicular lean soft tissue. And then when you remove skin and connective tissues, you have your appendicular skeletal mass. And so what I'm going to focus on here for both appendicular and just general lean soft tissue is the ALST. And so this is our muscle and skin and connective tissue. Now moving on, our expected outcomes with this study, we expected that increases in fat mass would be greater than increases in lean soft tissue or appendicular lean soft tissue, particularly at higher BMI. We predicted that increases in our lean soft tissue and appendicular lean soft tissue would be associated with greater increases in our pulmonary function. And so a little bit of why we had these expectations. So first of all, just thinking about fat mass and its relationship with body mass index. So this is in a general population, kind of trying to understand the validity of BMI and how BMI relates to our fat mass index. On the left, you'll see here a 6-year-old, and you can see that fat mass index doesn't really relate to the BMI Z-score until this inflection point. And the inflection point at 6 years of age is somewhere around a BMI Z-score of 1. In contrast, in 17-year-olds, that inflection point occurs a little bit earlier. So at BMIs greater than 0, you start to see that increase in fat mass. Now, I think it's even more challenging in individuals with CF because we have other differences in our fat mass relationship to our BMI. And so this study from Jessica Alvarez and her group looks at this defined normal weight obesity in CF, where you can see in the first panel that the BMI is the same in these individuals that are ascribed normal weight obesity versus lean. And despite that, the percent body fat, which is what they kind of make their criteria based off of, the percent body fat is above 30%, and so higher than the lean individuals and actually kind of on par with what you see in overweight and obesity. And then the final panel just looks at the fat mass index, and so you can see individuals with normal weight obesity have a greater fat mass index than lean individuals, and not quite to overweight or obesity, but the percentage body fat is the interesting component there. So then thinking about, what are our expectations following ETI therapy? And I think we would all hope that we're going to see that our body mass increase is related to lean mass and hope for that. But this study informed some of our predictions. So this looked at 36 adults with CF out of Madrid. This is a prospective single center observational study. They did bioimpedance, not DEXA, before and 6 months after ETI treatment. And they showed that there was a significant increase in BMI, fat mass, and visceral fat area, but unfortunately not muscle mass or fat-free mass. They also showed that with greater changes in BMI, there's greater increases in fat mass, and then not pictured there, but they showed an inverse correlation between the pulmonary function and fat mass, age, and visceral fat area. They showed a direct correlation between FEV1 and body cell mass, which is another marker of our lean mass. So they conclude that CFTR modulator therapy leads to improvement in FEV1 and improved nutritional status, but definitely warranting further assessment of the body composition components. So that their finding of the lean mass association definitely correlates with what we've seen previously in the literature. So Sabashek and the group at CHOP looked at 218 individuals with pancreatic insufficient CF with DEXA and showed the relationship between increasing lean mass and increasing FEV1% predicted. Jessica Alvarez looked at 32 adults with CF using air displacement plethysmography and showed again that with higher fat-free mass index, we see higher FEV1% predicted. And lastly, Kevin Scully and his group showed that 38 adults with youth and adults with CF, looking at DEXA measurements, their appendicular lean mass correlated with the FEV1% predicted. So moving back to our study, now that we have that background, this is the simple part of the methods. We use standard descriptive statistics to describe participants' disease characteristics and outcome measures. We converted those components that I mentioned into indices. So similar to BMI, we have the body composition component in kilograms divided by height and meters squared, and then converted those to Z-scores. So I didn't talk as much about the reference data as Megan had discussed for the bone component, but there are similar reference ranges available to us for body composition. We have NHANES for individuals with a baseline age above 20, and then we have that BMDCS cohort for individuals with a baseline age less than or equal to 20. Now, this is where it gets a little more confusing. In terms of our statistical analyses, we use longitudinal mixed effects models using visit as a fixed effect and the individual participant and site as random effects. And then we used seemingly unrelated estimation to compare the beta coefficients for body composition Z with the BMI Z. So we compared the relationship of BMI Z with these different body composition components to understand if there was a predominance of one or the other at baseline and then at the end. Similarly, we used other modeling, generalized structural equation modeling, to look at the changes over time to try to understand if the relationships of these different body composition components with the BMI-Z changes differed. And last but not least, we used mixed effects linear regressions to test the relationships of pulmonary function as our outcome with the body composition changes. We then conducted additional analyses adjusting for fat mass and lean mass in the reverse to clarify which was really the primary contributor to the change in pulmonary function. And so this is just kind of baseline data, and really, sorry, there's a lot of numbers, but the main thing I just wanted to point out for you all, one, this is a really robust study in terms of the numbers. So we had 131 individuals at baseline overall, 59 youth and 72 adults. And then you'll see that weight Z, height Z, BMI Z all kind of are right around the Z-score of 0, with height being just below. In terms of changes in anthropometrics for youth, we see that the weight Z and the BMI Z did increase from baseline to 12 to 18 months, but then came back down to prior at 24 to 30 months. There was no change in height Z. In adults, we saw that the change in weight, BMI, and BMI Z score that increased from baseline to 12 to 18 months did not change further, but persisted at 24 to 30 months. And so now looking at the body composition Z-scores over time. So first I'm showing you the baseline data for those less than or equal to 20 years of age at enrollment. And you can see the red dotted line is at a Z-score of 0. And when we use that statistical modeling, we can see that the fat mass in youth is higher for a given BMI than the lean soft tissue or appendicular lean soft tissue. When we look at the changes over time at 12 to 18 months, we did see an increase in BMI-Z, FMI-Z, lean soft tissue, in LSTI-Z, and appendicular LSTI-Z. You might appreciate in this graph that the median that's showing in the box plot is a little bit lower at the 12 to 18 month marks, but the stars that designate a p-value less than 0.05 are using our statistical modeling. So we're accounting for the baseline data and modeling the change over time. Obviously, there's different numbers throughout and other components that go into that. With youth, we did not see that those changes persisted at the 24 to 30 month mark, with the exception of appendicular lean soft tissue. And so when we looked at the changes over time compared to BMI-Z, there was no difference in the change in fat mass, lean soft tissue, or appendicular lean soft tissue over that time. And so really that relatively low lean soft tissue index Z and appendicular lean soft tissue index Z that we saw at baseline persisted at the conclusion. In terms of adults, again, looking at the Z-score of 0, the fat mass index Z, LSTI-Z, and ALSTI-Z are all below 0 now. And we did not detect a difference in contrast to youth compared to the baseline, although you can appreciate graphically the appendicular lean being lower below 0 than the others. We do believe that some of this is related to the use of the NHANES reference data, which is enriched in overweight and obesity. And so we're kind of maybe underrepresenting some of the fat mass there. When we look at the changes over time, you can see that all 4 do increase at the 12 to 18 month marks. And in contrast to youth, they increase at the 24 to, they maintain the increase at the 24 to 30 month mark. And they did not change different from one another in comparison to BMI. So I've been talking about Z-scores this whole time. I've been talking about the relationships with BMI-Z. We did wonder if that was causing any challenges in our data. So obviously in youth, it is really important to use Z-scores. Looking at the CDC curve, you can see just the changes that naturally occur over time. And so using an absolute BMI would be challenging. And so the Z-scores give us that opportunity to understand some of the changes that happen. However, I want to point out that a change in one z-score, a 1-point change in the z-score, is not the same at every point in the curve. So here's, if you were at the 15th percentile or so, and you increase by 1 standard deviation, that would be about a BMI change of 3. And in contrast, if you were at the 50th percentile and had an increase by 1 standard deviation, that would be about a 4.5 BMI change. And so we did also analyze that data looking at the absolute indices instead of the z-scores, and we did not see a difference in youth from what I already presented, but we did see with adults that maybe there's more fat mass index gain for a given BMI-Z compared to lean soft tissue index. Moving forward to our relationship of FEV1 % predicted with the change in body composition Z, you can see that all of these components, all of these changes do relate to increases in BMI-Z. However, when we adjust the fat mass index Z for lean soft tissue and appendicular lean soft tissue separately, that significance falls out. And so our thought is that some of that change is more related to the lean mass change as opposed to actually the fat mass change. And what I showed you so far was in youth, and then in adults, it's really not much difference. So in conclusion, there are relative lean mass deficits notable at baseline. The BMI increases following ETI are met with persistence of lower lean soft tissue, but in contrast to what we've seen before, neither fat mass or lean soft tissue increases predominate in the increases in BMI in youth, and maybe there's some increase in fat mass relatively to lean mass in adults, although we need to look into that a little bit further. Also, lean soft tissue, as has been shown previously, the increases there more closely align with the pulmonary function increases. And so for future directions, as we kind of pursue the data further, we'll explore if those with BMI-Z less than 0 are additionally compromised. And I had mentioned too kind of our interest in looking at people on different areas of the BMI spectrum and how the changes are kind of paired out accordingly. We also obviously need to look at the future implications. How does this relate to pulmonary health? How does this relate to cardiometabolic risk? And so that will all require long-term investigation. And I'm curious to hear what questions there are so that I can see what other future directions we need to explore. But thank you very much to the CHOP-CF endocrine team, of course, led by Dr. Andy Kelly, our nutrition and growth director, Babette Zemmel, who's provided a lot of insight for us, the PROMISE endocrine sub-study for allowing me to work on and present this data, Layla Farhan, who worked with me through the CFF traineeship program last summer and helped with a lot of these analyses. And then, of course, the Envision program for all of the support, and especially Kara Hugan and Scott Blackman, who are my mentors. So thank you very much for your attention, and happy to answer any questions.
Thanks, Marissa, for a really clear presentation of a really complex set of data. My question is about nutrition counseling for patients in the PROMISE study. Was there any standardization across sites of what type of counseling parents and patients were given as they were starting modulators?
There was no standardization of the nutrition counseling there. Thank you.
Do we have any?
Oh, that's a great question. I think that there's certainly been a lot of talk recently as we're noticing the changes in body composition, as we're noticing the increases in BMI. But of course, the historical CF is, always really aiming for a higher BMI and higher BMI associating with our pulmonary function. I think as it becomes clearer what components of BMI are contributing and, what additional modifications we need to make to our nutritional counseling, we'll be able to offer more customized guidance. But I'm not sure that at the beginning of this that all of that guidance was given fully. And I think, probably still at some places the push for higher BMI can still be there.
I want to acknowledgement and that those first 12 to 18 months occurred during COVID. So it's sometimes difficult to distill the impact of COVID related changes and
Yes, thank you, Andy.
Show your conclusion slide again.
Oh, sure.
There was a request to show her conclusion slide for another view, and we're open for maybe one more comment or question. This is fantastic work, and I'm looking forward to hearing more as the final data comes together. Thank you
very much.
Perfect. All right. I'm excited to introduce Dr. James Park, who is a clinical assistant professor in the hospital division of the University of Texas Southwestern. He just completed his internal medicine residency in June and currently is applying for fellowship in pulmonary and critical care. He's been involved in various clinical research projects in CF, including the use of GLP-1 agonists in weight loss and in CFRD, and also this work in hypogonadism in male adults with CF that he will present to you today.
Hi, my name is James Park, and I have nothing to disclose. And I'm very thrilled to be giving a talk on looking at testosterone levels in male adults with CF before and after ETI, utilizing the PROMISE study. So, what has been known so far about hypogonadism in male adults with cystic fibrosis, and why this is an important topic to explore? So hypogonadism in general population has been associated with decreased muscle mass, decreased bone mineral density, as well as depressed mood. And there have been several kind of a cross-sectional case report studies also on looking at hypogonadism in male adults with CF. So how we diagnose hypogonadism is by looking at the total serum testosterone concentration. And usually we look at the early morning levels drawn between 6 and 10 a.m. and consecutive measurements of total serum testosterone level below 300 is usually how we diagnose hypogonadism. And we look at other hormones, including LH and FSH, to differentiate primary from secondary hypogonadism. And in terms of what we know so far about male adults with CF, there was this one study from 2003, it was pre-ETI era, that looked at around 40 males with CF with average age of around 24.7. And they found the mean total serum testosterone concentration to be around 458. And the prevalence of those with total serum testosterone level to standard deviation below mean to be around 25%, which is quite higher than what has been reported in general population, anywhere between 4 and 12%. And similarly, there was one study from Emory, more recent study published in 2023, that followed 69 males who followed at Emory CF Clinic between the years of 2016 and 2023. And when they looked at the mean total serum testosterone level, they found it to be around 421, and around 28% of men had testosterone value below 300, similar to what was reported in the case report from 2003. So our study aim was utilizing the PROMISE database, which we know is a multi-center study, to answer the same questions. What is the mean total serum testosterone level in these individuals before ETI, and what's the prevalence of hypogonadism in this study cohort, and how the testosterone level changes after these individuals get started on the ETI. And just for the recap, the PROMISE study was looking at the impact of ETI on individuals at least 12 years of age and at least one copy of F500 delta heterozygous mutation, and various outcome measures were measured, including their person-predicted FEV1 as well as their sweat chloride. But one thing I want to stress is that at the baseline visit, before they were started on ETI, these individuals should not have been on any new antibiotics or systemic steroids within 14 days of baseline visit, meaning that they must have not been acute exacerbation at the baseline visit. So how we utilized this PROMISE data set was we only included males with ages of greater than 16 years, and we reviewed the medication list from the PROMISE database and made sure that they were not on chronic prednisone, meaning that not on chronic prednisone for like ABPA, for instance, or not on chronic testosterone therapies, at least on the medication list that we could pull from the PROMISE database. And those that had testosterone level available at the baseline visit so that we can track changes in the testosterone after they get started on ETI. So that left us with around 145 male patients who met the inclusion criteria, and we focused specifically on 3 visits. So first visit was baseline visit, and then the second one was 1 month post-ETI, and what's labeled as visit 5 was 12 to 18 months post-ETI. And there are 3 subsets of outcomes we were focused on. So first is the PFT parameters, looking at their person-predicted FEV1. And we also obtained the serum samples from the PROMISE database, and we used the MES spec to get the total serum testosterone level, as well as other important hormones, including LH and FSH. And we also were able to obtain sputum and serum inflammatory biomarkers from Dr. Sagel's lab. So the first result I want to focus on is what was the baseline patient characteristic at the baseline visit before these 145 male individuals were started on the ETI. And what we found, quite surprisingly, was that the mean total serum testosterone level to be around 568, which was quite higher than what was reported in previous case reports and retrospective studies. And their mean age was around 28 and mean BMI about 23. So the age was similar to the previous studies. And we also looked into several factors that do influence testosterone, that have been known to influence testosterone level. So first one was age. So we broke down this patient population into 3 different age groups. And we looked at whether there was any statistical significant difference in testosterone level amongst these 3 different age groups and at each of the 3 visits. And we did not find statistical significant difference across these 3 age groups. As I mentioned earlier, the timing of the testosterone collection is important, and we were able to get that timing data only for the 12 to 18 months post-ETI visit. And we looked at whether there was statistically significant difference in the testosterone level, whether or not it was collected before or after 10 a.m. And we did not find statistically significant difference. So now we reviewed that the mean total serum testosterone to be quite high at a baseline visit. Then we asked, what was the prevalence of hypogonadism, meaning how many of these individuals had testosterone level below 300. And what we found was that the prevalence was quite lower than also what was previously reported, around 6.2% at the baseline visit, and even lower at 12 to 18 months post-ETI. And in terms of looking at the testosterone level changes over time, we utilized the generalized estimating equation model, and we adjusted specifically for the BMI, age, as well as prior modulator use. And what we found was that the change from the baseline visit to 12 to 18 months post-ETI, there was no statistically significant difference. But there was statistically significant difference between 1 month post-ETI to 12 to 18 months post-ETI. But the clinical significance of this finding remains yet to be determined, as much as the degree of increase was small and the level was high to begin with. So our study, utilizing the PROMISE database, what we showed was that the prevalence of hypogonadism was low, both pre and post ETI. And ETI led to the change in testosterone level, but clinical significance remains to be determined. And that kind of leads us to the second part of our study, as much as we've had data on their pulmonary function test, as well as the sputum and serum inflammatory biomarkers. And we know, and there have been previous studies that show that sex disparity exists in pulmonary outcomes in people with CF, especially women with CF are more likely to have pulmonary related exacerbations, and the difference persists after the ETI use. And the role of estrogen, the negative role of estrogen has been studied, but it's not clear whether there is any significant relationship between testosterone and lung function. So, and that there has been also a previous study from, like in the general population from Western Australia, that was population-based study that looked at the early morning serum testosterone, and they looked at the correlation with the FEV1 and FVC, and they found the statistically significant positive correlation between testosterone level and the FEV1. And in terms of correlation with inflammatory biomarkers, this review article cites several animal-related studies that showed testosterone to have inverse relationship with sputum IL-6. So we utilized this PROMISE dataset to ask what was the relationship between testosterone and lung function in male adults pre and post ETI, and also what's the relationship between testosterone and sputum and serum inflammatory biomarkers. So for the first part of the result, I'll lay out we used the Spearman correlation test, and we found that across all three visits with none of the PFD parameters, including percent predicted FEV1 or percent predicted FVC, we did not find any statistically significant correlation between total serum testosterone and this lung function test. But what we also did was that we broke down the study population into three different groups. The one with no obstruction, and then one with mild to moderate obstruction, and the one with severe obstruction. And we utilized gamma regression model to see how the trend in testosterone level change is different across these three groups with different degrees of ppFEV1. And what we found was that there was trend towards greater level of testosterone increase in the severe obstruction group, but to note that the sample size is pretty small, and there's really high variability in the sample results. And in terms of looking at the relationship with the different inflammatory biomarkers, I specifically focused on the inflammatory biomarkers that have been implicated in lung function of people with CF, including sputum neutrophil elapsase, as well as blood HS-CRP. And we looked at the correlation between testosterone and sputum and serum inflammatory biomarkers at visit 1, as well as visit 5, which is 12 to 18 months post-ETI. And we found the total serum testosterone to have consistently inverse relationship with the sputum TNF-alpha, but the statistically significant only existed at 12 to 18 months post-ETI, but not at visit 1. And in terms of relationship between total serum testosterone and blood HS-CRP, the relationship varied. So at the visit 1, it was inverse relationship, whereas at visit 5, it was positive relationship. So the total serum testosterone had varying levels of relationship with the blood HS-CRP. And we did not find any statistically significant relationship with either sputum neutrophil elapsase or sputum IL-1 beta. And we also looked at the changes in these inflammatory biomarkers over time, kind of from pre-ETI to post-ETI. And these data are from Dr. Sagel's lab, and more information on the actual changes in inflammatory biomarker will be available. But what we studied was there any interaction effect with the total serum testosterone level? And although we do see the decrease in both sputum TNF alpha and blood hsCRP from going from pre to post ETI, but the serum total testosterone did not have any interaction effect with the sputum biomarkers over time. And the same goes for the sputum neutrophil elapsase as well as with the sputum IL-1 beta. So what we've found was that the total serum testosterone did not have statistically significant correlation with the PFT parameters, and we did not find consistent relationship between total serum testosterone and any of the inflammatory biomarkers we studied. So I think kind of that concludes kind of our study. So first finding was that the prevalence of hypogonadism was low, both pre and post ETI. And I think that kind of speaks to that at the baseline visit, the individuals must not have been in acute exacerbations. And one of the purported mechanisms underlying hypogonadism in people with CF is through dysregulation of HPA axis from frequent prednisone use and from frequent pulmonary exacerbations. So maybe that speaks to why the prevalence of hypogonadism was lower than what was reported in our study population. And ETI led to statistically significant change in testosterone level from 1 month post-ETI to 12 to 18 months post-ETI, but the clinical significance of this finding remains to be determined, and there was trend towards greater testosterone increase in individuals with most severe airway obstruction at baseline, and total serum testosterone level did not have statistically significant correlation with the PFT parameters or with majority of the inflammatory biomarkers we studied. But just to go over the limitations of our study, so first, it would be generalizability of our study population, whether the prevalence of hypogonadism we saw in the PROMISE database can be applied to other CF centers kind of remains to be determined. And also, I think the most limiting factor was that although we did get the medication list from the PROMISE study, it's not really clear that whether some of the individuals were getting kind of off-the-market testosterone supplements, and that may have swayed our finding. And also, although we did have timing of testosterone collection available at the visit 5, we didn't have the data available at either baseline visit or 1 month post-ETI visit. And although the sample size was 145, I think a bigger study would leave us with a more better conclusion. So I'd like to thank PROMISE investigators as well as wonderful people who've been involved in the study, wonderful statistician, and Dr. Jane. And I think that concludes my talk. Thank you so much.
That was incredible. And as a resident, I wanted to just mention to you that, there's still time to go into endocrine. You don't have to do pulmonary. That was fantastic. And this data is so helpful. It really fits with my clinical experience where I feel like, we're not seeing much hypogonadism as we do. So this is really, really helpful. I wanted to ask, it's great that you collected SHBG. And with all the weight gain that we're seeing in, post-ETI, look at changes in SHBG in this population.
Yeah, so we do have SHBG data available, and we're also looking at that analysis and SHBG changes over time. And also interesting would be to look at the relationship with the BMI as well. So yeah, thank you.
Very nice presentation. I wanted to ask about the LH and FSH level. Did you have that at subsequent time points? And did you look at the pattern of what was the hypogonadism found? Over time, was it LH was elevated? Was it a pattern of primary hypogonadism in these patients, or like a secondary hypogonadism picture?
Yeah, so we primarily focused on the total serum testosterone level, and just to see how many of these individuals had total serum testosterone level below 300. We are in the process of looking at the LH and FSH levels and tracking changes, so it's hard to tell from this data alone whether differentiate primary from secondary hypogonadism, but certainly would be a very interesting further next step for the project.
Thank you for an excellent presentation.
Yeah.
We look forward to more data coming in.
Hello. I'm excited to introduce Dr. Amy Downs. Dr. Downs is a senior clinical fellow in respiratory medicine in the UK who is currently working at the Royal Brompton Adult CF Centre in London. She is doing a PhD in pregnancy and parenthood in CF under Dr. Imogen Felton. Welcome.
Thank you, and thank you for the invitation to present this. So the title of the work I'm presenting today is that pregnancy and really early parenthood does not have a detrimental impact on the CF health of the females under the care of our dedicated CF maternal health service. I have no disclosures. And so the background to this, which is something that we did as kind of an evaluation of our service, is that there are studies that have shown that particularly that really early parenthood stage, there has been detrimental impacts for females with cystic fibrosis. But a lot of that research was done prior to this really widespread use of ETI. But also, as I think somebody else mentioned, even before modulators, there were real advancements in sort of healthcare, health stability for all people with CF. And given that, we wanted to kind of relook at this data within our own service and say, well, is this still the case or have things changed? And that's within our sort of dedicated CF maternal health service. So for a little bit of context, I work at the Royal Brompton. We're a large adult CF service. We have approximately 630 adults in London. And in 2021, in response to sort of a really great need, Dr. Felton set up the Royal Brompton Maternal Health Service with our local obstetric unit. We're an entirely lung and heart hospital, so we don't have an obstetric unit on site, but we do have very close links with a hospital that is very local to us. It's a multidisciplinary service, so it's got CF physicians, but also our specialist nurses, obstetric physicians, specialist dietitians, pharmacists, and physiotherapists. And as part of that, we run a virtual monthly clinic, and that provides preconception counselling. We see our females with CF, when they're pregnant, we try and see them virtually monthly throughout the pregnancy. We can facilitate, because it's a virtual clinic, we can actually do joint clinical reviews with their obstetric units. So I know it'll be a very small map, but for a bit of context, this is kind of the area of southeast of England that we cover. There's a little blue dot in the middle that's the Royal Brompton Hospital, and then the yellow prams represent obstetric units around the southeast of England where we've had people give birth under our care. So it's a widespread area, and actually increasingly people want to be able to give birth local to where they live. If you're in labour, travelling 2 hours to London is very unappealing. So being able to kind of have that virtual link is something we've had a lot of positive feedback on. And we do postpartum reviews as well. And I've included a bit of social context, which I'll talk a bit more about how that links into our research, but I think it's relevant to say in the UK, we have a slightly different statutory maternity leave policy. So women are entitled to up to 52 weeks of maternity leave. And this is a protected right. There's obviously sometimes issues, I'm not going to lie, but generally you've got 18 months of protection from redundancy. So if you take your 12 months, you should be entitled to return to the job that you came from or an equivalent. So it's quite protected. And there is a government payment for the first 39 weeks of that to try and enable people financially to take as much as possible. This means that it is common for people to take between 9 months and a year of maternity leave and then return to work. And we do have some childcare funding. It's between 50 and 30 part-funded hours. And that kicks in now. That's recently been decreased, and that now starts from the age of 9 months up until 4 years. So again, there's access there to try and encourage either return to work or putting children into a kind of preschool setting for their own social development. So we wanted to look at our service. So it's a single centre retrospective review, and we focused on body mass index and spirometry, specifically FEV1. and we reviewed where they were pre-conception and up to 2 years postpartum. And that's that relevance I was saying about that 1 year maternity leave. What we really wanted to capture was not just that first year when perhaps they're at home with a newborn, but also around the time when children are going into childcare settings, women are returning to work, and obviously the exposure then to different viruses changes. And we thought it was really important to make sure that was included in the data we're capturing. And so we looked at female with CF who gave birth between 2020, which is just at the very beginnings of the maternal health service, and 2023, 2 years ago now. And so we looked at data for an overall cohort, which was 40 pregnancies in total, and then broke down into some subgroups that we thought were potentially more at risk or might give us more information. And I'll talk more about those shortly. So as I said, we had 40 pregnancies. We had 37 females with CF. So in that 2 to 3 year period, 3 of them actually delivered twice. 42 infants with 2 sets of twins. There weren't any stillbirths or late-term miscarriages. The mean age was just over 30 years, which I think is fairly consistent with both UK data and data that I've seen in other pregnancy and parenthood studies, even the last couple of days, with a range between 18 and 41. So it's quite a wide range. We didn't show, when we broke down into the subgroups, I think it's important to say that there wasn't a statistical difference in age or the baseline BMI or the baseline FEV1 compared to this overall cohort, unless they were specifically selected on one of those characteristics. So none of those groups were outliers in that. We had 24 of those pregnancies were a first pregnancy, nulliparous women. I think it's notable to say 6 of them were already pregnant at the 1 year postpartum review that we were doing. And we had to exclude 13 of them from the 2 year BMI analysis because they were either pregnant again or they'd already completed a full second pregnancy and had only recently given birth, and we felt that would skew the data. So the overall outcomes, we didn't find a significant change in FEV1, either from the baseline to the 1 year or to the 2 years postpartum. So certainly none of the detrimental impact that we were concerned about. And we did actually find a significant increase in BMI from their preconception to 2 years post. So rather than having a detrimental impact, it seems to have, if anything, been positive. And this does stay within a normal range for BMI. So this isn't sort of a development of obesity or something that we might see as a negative. And that kind of was our headline data. But we did think, okay, is there a particular group that's maybe skewing this or a group that didn't do so well? So we kind of split it down into some of the ones that we picked out. And one of that was we wanted to look at women who were having their first pregnancy but were already on ETI. By the nature of the time frame we were looking at, some of those women who were delivering 2020, early 2021, they hadn't started ETI prior to their pregnancy. It was relatively new over in the UK. The data was still coming out of the United States, and they felt actually without better information on the safety, they would rather delay it. So what we didn't want to do is see this increase in BMI and potentially FEV1 because they'd all finished their pregnancy, started ETI, and everything improved. So we took out this group that had kind of not got those confounding factors. And although it's a small group, so there was 11 of them to start with, we didn't see any decline. And I think we do see a very slight trend towards increase in the BMI. It's too small to be statistically significant, and that's going to be the theme for all the subgroups. But it's not that this group had the massive uplift that is kind of overcompensating for some of the others, which is what we're worried about. We looked at unplanned pregnancies. It tends to be more pregnancy data that suggests they have worse outcomes, but they are a more at-risk group. 9 of these were unplanned pregnancies, which is 22%, and it obviously doesn't reflect that there were unplanned pregnancies that weren't completed. That was a high percentage, but actually, even within our overall cohort of completed and non-continued pregnancies, that's really significantly decreased over the years. And I think that this high number reflects that massive, slightly unexpected increase that was seen between 2020 and 2021, and actually with better preconception counselling, awareness of contraception, and the fertility impact of modulators, that number has decreased. And again, these women didn't have any detrimental impact. We have 10 pregnancies that were in women with an FEV1 that was less than 50% at baseline. So when they went into pregnancy, and we particularly picked those out because they would have been a cohort that would have once been pregnancy would have been considered to be contraindicated actually from a safety perspective. And they did do well. There is actually an noted increase in their FEV1, although again, with 9 of them, 10 of them, it's not statistically significant. It's worth noting that 2 females with CF actually account for 4 of these pregnancies. So there's probably a little bit more to unpick there because they're obviously a hefty percentage of that. And we looked at breastfeeding. So 14 of our women breastfed for over 6 months, which is 35% of the total cohort. And that's about in line with what we see in the UK. About approximately 35% of women are breastfeeding at 6 months, and that's combination or exclusively. Our longest duration of breastfeeding was a woman who breastfed for 18 months. And so we thought, what is the impact of that? It's time consuming, it's got a high calorie burden, it affects your abilities to do your CF treatments potentially because you have a baby attached to you. And again, these women didn't seem to deteriorate in the case of their FEV1 or their BMI. So this is the same data, but I've just put it together a little differently because I think it's quite nice to see. So this is the FEV1. Again, I know I'm repetitive, it's a small number. We're not going to see big statistical significance, but I do think, given what I've just said, it's interesting that if we actually look at the FEV1s of the women who, for example, breastfed for over 6 months, they're running around the 80 to 90%, as opposed to perhaps the overall cohort where it was a lower average, and maybe that's indicative of their ability to kind of start and continue and do so safely. And then in BMI, it just shows the trend overall nicely. But as I said, nobody started with a very low BMI, and none of them gained weight to a level that we would be concerned about from a nutritional perspective. So they all remained what we would consider relatively stable, but you do see this uptrend in pretty much all the groups. The unplanned pregnancy group is the one that goes up and then seems to dip, but they didn't dip to below their pre-pregnancy level. So some of the things that, we thought were interesting about this, it doesn't seem that early parenthood, even if we extend it to the 2 years and cover nursery and nursery viruses, it doesn't seem to be associated with a decline in these CF prognostic markers in the women we're caring for. And that's independent of timing of ETI use or the sort of historical preconception risk factors for poorer outcomes. Some of the risks that we kind of theorize might be negative, for example, breastfeeding, they don't seem to have a negative impact. Although, as I've said, is that because the women that are able to continue doing so for a prolonged period of time are already more well? It's important to note, and somebody mentioned it, one of the previous ones, 2020 to 2023 covers quite a period of relatively intense lockdown in the United Kingdom. So I say return to work. Many of these women will have been working from home. If they did so, nurseries were intermittently closed. So I think it would be nice in the future, once enough time has elapsed, that we review this further out and see whether or not that's still, whether there's a different outcome now that we don't have such a severe lockdown. I think it was really interesting how many were choosing to have more than one child, and actually in quite short gaps. As I said, at 1 year, we had already 6 who were already pregnant again. And I know that some of the women in this have had 3 or 4 children, and that's just within one cohort. And it would be interesting to see, and I know there are larger prospective studies, both ongoing and being presented here today and tomorrow, that might help us confirm significance in that slight positive trend in the FEV1 and also a longer time impact. So with older children and multiple children, I think would be really interesting. So I'd just like to thank everybody at the Royal Brompton. I haven't listed them all, but some of them are here today. I'm very grateful for the support. And Chelsea and Westminster Hospital, which is our obstetric unit. And if anybody did have anything further after the session, I will be at poster 679.
Great presentation. While we're taking our first question from the audience, I was wondering, did you also look at pulmonary exacerbations and frequency and make any comparisons there?
We're looking at, and we haven't yet kind of pulled it all together, but yeah, we'd very much like to look at it both during pregnancy, of course, and then following pregnancy.
Thank you. Can you hear me? It's my fault. I asked for a new mic.
Help is on the way.
Hear it.
Hello,
try a yell.
Can you hear me? Well, I have another question. As a family planner, we obsess a little bit about the definitions of planned and unplanned pregnancy. And, you know, even though in a lot of our analyses we dichotomize that, obviously in real life there's a spectrum of planning that can occur. So I was wondering, what was your definition of planned versus unplanned?
So in some cases, it was quite straightforward. It was women who'd already had a preconception counselling. They'd come to us, they'd spoken. So a lot of it did depend on the woman's own definition. So it was something we'd kind of query about if they came to us and said, we're pregnant. And, you know, you'd sort of in that initial consultation, oh, okay, was this planned? Were you trying? Yes, I agree. I've had a lot of, oh, it wasn't planned, but I stopped my contraception and started having regular sex and went, That's sort of planned.
Right.
But yeah, generally we relied on their interpretation. And certainly in the early days, it did tend to be a bit clearer. It tended to be a bit more of a surprise versus, you know, that preconception. I've stopped everything. I've thought it through. So that's kind of how we largely differentiated it.
Nice.
I'm so sorry.
You want to come up here?
Yeah.
Yeah. Or say,
You can come up or.
Yeah, I think there probably is. And it was, oh, sorry. So it was that women without CF, generally there is a certain amount of weight gain post-pregnancy. And whether there's a benefit to comparing whether the rate is different in women with CF and women without, I think there is. I think both in pregnancy, because there are actually recommendations for weight gain during pregnancy, which is something we've kind of looked at. This was focused on parenthood, but whether our women are gaining adequate weight during pregnancy, which generally they are. And then again, as you say afterwards, it's actually one of the reasons we picked out the nulliparous women, because otherwise what you're doing is that building of pregnancy after pregnancy and then parenthood after parenthood. And actually, I know people say we're really busy running around after a toddler, but actually what you're not able to do is get to the gym, do the exercise that they were doing before. So yeah, I think that would be really helpful. I don't know if we've got good stats on what that weight gain is in the healthy population.
yeah. Going for it.
Obviously gave you good context about the differences and sort of which so there's like that support. But then did you also have data on like the social supports, other things like family, friends, community, and that how that might be variable?
We haven't unpicked that. Sorry, the question was about social support. So obviously talked about the context around being able to take that time away from work, but whether actually we'd looked at the social support available to, I suppose, women, paraphrasing, but are they in a committed relationship? Do they live with their partner? Have they got family nearby? We didn't unpick that. I think in a group that is, you know, is 37 women and it's 40 pregnancies, I think we're going to get so much diversity that it's going to be hard to pull out one individual. You know, I can think of individuals off the top of my head that had good or less good social circumstances, but it's a really individual person rather than a trend. Longer term, we would love to look at registry data, are looking at registry data for similar things. We won't get the detail on that, but we do have certain socioeconomic identifiers in the registry that might support that a little bit, but
Thank you so much. We're looking forward to your post-2023 cohort data.
thank you.
All right. We are rounding out our session with our last speaker. I'd like to introduce Dr. Monique Mayer. She is currently a dual fellow in adult and pediatric endocrinology at the University of Colorado. She was awarded the CFF Fellowship in Education Training Award, which supports her work and time on her topic that she'll be presenting today, utility of 1-hour glucose challenge test to screen for CF-related diabetes. Let's welcome her.
Thank you to NACFC and the workshop organizers for inviting me to talk. I am presenting on behalf of the authors listed here. I myself, as the presenter, don't have any disclosures, but I've listed disclosures for other authors on this slide for review. And I'll be presenting findings from a multi-center study on the test performance of the glucose challenge test for identifying abnormal glucose tolerance and CF-related diabetes, and comparing the glucose challenge test to other convenient tests that could be done in a clinical setting, such as the random plasma glucose, random capillary glucoses, and hemoglobin A1C. So cystic fibrosis-related diabetes is linked with increased morbidity associated with lower BMIs and lower FEV1. And the gold standard for screening currently includes an annual 2-hour oral glucose tolerance test that is recommended for all individuals age 10 and above. And in practice, the oral glucose tolerance test is cumbersome and screening adherence is suboptimal. And here I show data from the CFF patient data report from 2023 with OGTT screening rates are shown with the green lines. For individuals under the age of 18, that's shown in the dashed line. And you can see that in the most recent years, screening rates have ranged from 60 to 70%, and for those greater than or equal to the age of 18, screening rates are much lower at between 30 and 40%. So we set out to see if a non-fasting 50-gram, 1-hour oral glucose challenge test could be used as a first line in part of a 2-step screening algorithm for CF-related diabetes. And we set out to define whether a glucose challenge cutoff that provides a high sensitivity and a reasonable specificity. And we also set out to compare the glucose challenge test to other convenient in-clinic tests. This was an observational study that recruited people with cystic fibrosis from Emory, University of Minnesota, and the University of Colorado between 2012 and 2022. We included those aged 10 and above who had a stable medication regimen in the preceding 3 weeks and stable lung function at the study visit that was within 10% of their highest FEV1% predicted within the last year. We excluded those already with an established diagnosis of diabetes who had exposure to systemic steroids within the preceding 6 weeks, who had a pulmonary exacerbation requiring IV antibiotics within the preceding 3 weeks of the study visit, or who were pregnant. And participants who were already due for an annual screening were recruited to undergo the glucose challenge test at a routine CF clinic encounter. And then random plasma glucose, capillary glucose, and hemoglobin A1C were obtained prior to the glucose challenge test. OGTT then followed the glucose challenge test within 2 weeks. So what is a glucose challenge test? It is a glucose load that is given at a maximum of 50 grams and it's weight-based at 1.17 grams per kilogram, and it's administered regardless of the fasting state. Random plasma glucose and capillary glucose values were obtained prior to giving the glucose load, and then plasma and capillary glucose values were obtained 1 hour following the glucose load, and that's the GCT plasma and GCT capillary values. We defined the glucose tolerance category by the OGTT results. Those with a normal fasting plasma glucose that was less than 100 and had normal 1 hour and 2 hour OGTT values were defined to be normal glucose tolerance, or NGT. Impaired fasting glucose were those with a fasting plasma glucose between 100 and 125 with a normal OGTT at 2 hours. Impaired glucose tolerance were those with fasting plasma glucose less than 126 who had an OGTT at 2 hours between 140 and 199. Indeterminate were folks who had an OGTT at 1 hour greater than or equal to 200. CF-related diabetes was defined as having a fasting plasma glucose greater than or equal to 126 or an OGTT at 2 hours that was greater than or equal to 200. And abnormal glucose tolerance were anybody who did not have normal glucose tolerance. So our results. This shows the demographics of our study population. We included 185 individuals with cystic fibrosis, and based on their OGTT, 94 had normal glucose tolerance, 81 had pre-CFRD, and 10 individuals had CFRD as defined by an OGTT. The median age for our study population was 16, and this was not different across each of the glucose tolerance categories. sex, race, and ethnicity were also not different across glucose tolerance categories for our study population. BMI for those greater than or equal to the age of 20 had a median of 23.6, and you can see that this was also not different across glucose tolerance population. BMI percentile, specifically for those under the age of 20, had a median of 57th percentile, and you can see the CFRD group had a median percentile of 37th, but this was not statistically significant. The FEV1% predicted was an average of the two highest FEV1% predicted in the last year, and this was statistically significant between the NGT and the CFRD on pairwise comparison with a p-value that was exactly at 0.05. Pancreatic insufficiency was statistically significant across the glucose tolerance categories, and hemoglobin A1C had a mean of 5.5%, with statistical significance seen between the NGT and the pre-CFRD group on pairwise comparison. Here we compare what the glucose values look like on the OGTT at 2 hours and the glucose challenge test. And I've shown the values for the glucose challenge test for each glucose tolerance category as median with quintile ranges in the parentheses. And you can see with the glucose challenge test, the value rises as the glucose tolerance worsens. However, the rise that's seen in purple is not as robust as what's seen in orange from the OGTT. One explanation for why that is that the glucose load that's given in a glucose challenge test is not as much glucose that's given in OGTT. Additionally, this is a non-fasting test, and so potentially the non-fasting state could explain the lack of robust rise. However, there is still a clear distinction between each glucose tolerance categories using the glucose challenge test across all three, and it is most obvious and distinct when you put the NGT group alongside the CFRD group, where the GCT can clearly distinguish between these two groups. I'm going to do a small statistics break to explain the receiver-operator curves. We'll look at those next for the tests that we evaluated during the study. The receiver-operator characteristic curves are useful, and they plot the true positive rate against the false positive rate. We look at the area under the curve, and if the area under the curve is at 0.5, that means the test performs as well as chance for detecting the diagnosis. In general, an AUC that is over 0.7 is an adequate test, and over 0.8 would be an excellent test. Additionally, this kind of statistics is advantageous because it can help us identify a cut point for a test that we're using, depending on what the goal of that test may be. So a cut point that maximizes the true positive rate and minimizes the false positive rate and optimizes both together would be considered the Uden index, and that would be one way of identifying what an appropriate cut point is. But different cut points may be decided depending on what the utility of the test, the purpose of the test is, and we'll look at that a little bit more closely too later on. So here I show the GCT plasma compared with the GCT capillary, random plasma glucose, random capillary glucose, and hemoglobin A1C with their ROC AUCs, Uden indices, and other test performance characteristics. And you can see that the GCT plasma has the highest ROC AUC at 0.73 with the confidence intervals present in the parentheses, and it identified a Uden index at 141 for identifying abnormal glucose tolerance. This gives a specificity of 71% and a sensitivity of 71%. And you can see also that the sensitivity provided by this cut point at 141 is the most sensitive compared to the other tests that were done during our study. Looking exclusively at those with cystic fibrosis-related diabetes, the GCT plasma again has the highest ROC AUC at 0.75, giving identifying a Uden index of 147, and this gave a specificity of 58%, but a sensitivity of 90%. Again, the ROC AUC for GCT plasma was the highest compared to the other tests we looked at and gave the highest sensitivity. So this shows what the study population distribution would look like if the Uden index was used to detect a diagnosis. The Uden index is the dashed line across the study population distribution, and those with CFRD are shown with the black dots on the right side of the panel. And you can see that at a Uden index of 147 using that GCT plasma, a single person with CFRD in our study population would be missed at that cut point. When you compare it to what the GCT capillary, more individuals at the Uden index for GCT capillary would be missed with CFRD. And the random plasma glucose and random capillary glucoses at their Uden indices would miss somewhere in between what the GCT plasma can detect and the GCT capillary. And finally, looking at how the hemoglobin A1C would split up our study population at its Uden index, about 3 individuals using hemoglobin A1C would be missed with CFRD. So I use this panel to show you how a different cut point for the GCT plasma can change the sensitivity of the study. The Uden index, as a reminder, was identified to be 147, and that's our thickest, boldest dashed line in the middle of the panel. Using a more sensitive cut point at 130 would allow us to capture every single person in our study population with CF-related diabetes. It would also capture many other people in our study population that do not have CFRD. The opposite is true if we were to choose a higher cut point at 160. We may miss some individuals with CF-related diabetes, but spare many people who do not have diabetes from needing an annual screening that year. Depending on what the risk is of missing or delaying a diagnosis of CFRD and the general health of the population you're screening should go and inform what the cut point of a test should be. And looking at CFRD in the pre-modulator era, that was true. Having a most sensitive test had major implications for the health of the population. In the modern era, with better lung function and better nutrition, the consequences of having CF-related diabetes is not clear. But it may come with time and longer longitudinal studies that would inform that a more specific test that maybe is not as sensitive may be more appropriate to spare and protect the burden of screening for this population as it becomes healthier. Some strengths of our study. This is the largest prospective study on looking at the glucose challenge test in individuals with cystic fibrosis. It's multi-center and it included pediatric and adult participants with cystic fibrosis, so I would argue it's very generalizable. The limitations of our study is that once the OGTT was done, 10 of the 185 we included in the analysis were deemed to have CF-related diabetes. And this study is cross-sectional, which does not allow us to know the longitudinal outcomes of those who would be missed by a glucose challenge test for screening long-term. In conclusion, the glucose challenge test is a feasible in-clinic screening test, and a cut point of greater than or equal to 147 is 90% sensitive for CF-related diabetes screening, allowing it to be used in a 2-step screening algorithm. The GCT plasma in our study performed better than hemoglobin A1C and random glucose values. And currently, the data does not support using the glucose challenge test to replace an OGTT for the diagnosis of CF-related diabetes. I wanted to thank everyone who made the study possible and the funding that allowed us to support it. Thank you.
We don't have any questions coming in through our chat. Do we have any from our audience? Or maybe we can even ask, has anyone else outside of the study sites used the 1-hour glucose challenge test? Because I have not.
Yeah, I was going to ask.
Sort of.
Hello.
So the question was, with the data we have so far, is it enough to change practice? Honestly, I think it could. So just as some background, the Canadian guidelines in June 2024 started including a 2-step screening algorithm using hemoglobin A1C at a lower threshold than what traditionally is used for diabetes. And I think that this data is a good starting place to try to create something similar in RCF guidelines. So using the glucose challenge test as step 1, us as a medical community deciding what is a reasonable cut point for that glucose challenge test and who are we willing to delay a diagnosis of CFRD, knowing that they would go and get annual screening the next year. And I do think that this is like very strong data to start working towards that. But the longitudinal outcomes are really going to be what's most important to understand. If we delay CFRD for a year or a couple of years using this screening method, how will people be affected before we can actually start incorporating this in practice?
We do have one question from the app. Were post-treatment patients and those with CF liver disease included in your, post-transplant patients and those with CF liver disease included in your cohort?
I don't think so. I will say the demographics data we have from that cohort, which was over 10 years, at the time of that, they were recruited to do the glucose challenge test. With the multiple sites, we probably could go back and dissect if anybody was post-transplant, but right now, it doesn't seem like any were.
Wondering if you had considered possibly a mixed meal glucose test as opposed to just the glucola or the glucose test. I had been discussing with my endocrinologist, especially for those with reactive hypoglycemia that we've identified, possibly trying to use Ensure or something like that to do more like a mixed meal type glucose test.
Will you just repeat the question?
So the question was, did we consider using an alternative glucose load that is more mixed, like a mixed meal tolerance test, as a way of catching some of that reactive hypoglycemia that we know that this population can get, as well as screening for glucose intolerance? So we did not consider that for this prospective study. This study, which I didn't have enough time to go into the background, was kind of as a way of extrapolating the method that's used in pregnancy when screening for diabetes. And in pregnancy, they use a glucose challenge test that is a pure glucose load. And so that was the thought for how this study was designed.
I just want to answer your question. Sabashe in 2020, as part of her CF Foundation Award, published on 27 individuals who she compared the G16 to the typical OGTT. She as well found about 71% sensitivity or so with G16 glucose of 145 versus 36, so very consistent with the finding.
I'm just going to repeat that what was just shared. So Dr. Sabishek, I hope I'm pronouncing it correctly, in 2020 had a cohort of 27 individuals also looking at the glucose challenge test. And they also found a similar cut point of around less than or equal to 146 as being screened out, and had the similar sensitivity and specificity that we found in our study that included 185. We're hoping to publish this data, and that will be cited in that paper as well. So that will be coming out hopefully soon.
We have a couple more questions coming in through the chat. The first one is, would the recommendation be to only move to 2-hour OGTT in patients with a positive glucose challenge test? So reducing the burden of having all patients 10 years and above getting a 2-hour OGTT.
That's right. So that would be what we're trying to work towards with this data, is that a glucose challenge test that was less than 147 would then not go on to do an OGTT that year, and then the next year would screen again with a glucose challenge test. And anybody who was greater than or equal to 147 would then have to go get confirmed to have the diagnosis of CF-related diabetes with an OGTT. And with that data, with our data, which I also didn't have a chance to share given the time constraints, going under that model, we could spare up to 56% of individuals from needing an OGTT every year.
We have another online question. Is there a role for CGM to diagnose CF-related diabetes?
Yes, there is a role, and there's a lot of studies that are looking into this, including studies from my mentor, Dr. Christine Chan. That wasn't the focus of this talk, so I wasn't able to talk about it.
We have another question. Has anyone looked at a different OGTT positive rate in people with CF?
I'm not sure.
I'm
I
not
understand
sure
the
if that
question.
is a different cut point.
Do you mind just repeating it one more time?
Has
for me?
anyone looked at a different OGTT positive rate in people with CF?
I'm not sure what the question means, but if it's referring to should we be using a different cut point for OGTT, it's hard to compare OGTT against OGTT. The OGTT is considered gold standard. And so I think looking at different cut points would be a very creative way of trying to answer that question. I'm not sure.
The question may refer to the prevalence of CFRD and if that is less than the past. I think many of us feel it is less than the past, but there aren't actually any hard data.
I'll just repeat that for the whole group. The clarification of the question might be referring to whether the rate of CFRD has changed over time. And anecdotally and in practice, it does seem like as a community, we do feel like it has, but there isn't firm, strong data to support that.
We do have a few extra minutes if we wanted to open the floor to any additional questions for all of our speakers today. If there are no online or floor questions, we'll give you a few extra minutes to enjoy lunch and get to the posters. So we'll open things up. I might suggest coming up here closer to ask your question given the microphone challenge. Or all of our speakers are available to meet one-on-one up front. But we would like to thank all of our speakers for presenting their work today and for everyone in attendance. And to the Cystic Fibrosis Foundation and NACFC for supporting a lot of this work presented today.
Thank you.
Thank you.